Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on our discussion on the liver. Today we're going to be talking about cirrhosis. Cirrhosis is the replacement of normal functioning liver cells with fibrotic non-functional tissue. It occurs after repeated cycles of liver injury and healing, leading to scarring and the formation of regenerative nodules. This disorganized architecture severely impacts liver function. Cirrhosis can arise from a range of causes: metabolic conditions, including chronic alcohol use, steatohepatitis, iron overload, as seen in cases of hemochromatosis, and copper accumulation in Wilson's disease. Then we have infections such as chronic hepatitis B and C, which are common viral causes. And finally, autoimmune or inflammatory processes like primary biliary cirrhosis and primary sclerosing cholangitis. These can also lead to cirrhosis. So some of the intrahepatic signs of cirrhosis include the nodular surface or contour of the liver. Then you have some segmental atrophy and hypertrophy, especially with regards to the atrophy. You have segments 5, 6, 7, and 8, basically the right lobe undergoing atrophy, and then the left lobe, not the entire left lobe, specifically the lateral segments of the left lobe, that segments 2 and 3, would hypertrophy, whilst the medial segment of the left lobe, that segment 4, just like the right lobe, would also atrophy. Then we also have segment 1 hypertrophying, that's the caudate lobe, also hypertrophying. And in such a case, when you have a caudate to right lobe ratio of more than 0.65, that strongly suggests cirrhosis. Then because of the atrophy of segments 4 and segments 5, basically you would have the space around the gallbladder and the periportal area just getting wider, and these spaces would end up being filled with fat. You could have a sign that we call empty gallbladder fossa sign. That's because of this shrinking away of the liver parenchyma. And then when the segment 7 also shrinks away like that, you'd have a notch right in the posterior aspect of the right lobe. All these signs point to liver cirrhosis. So these images, we have an ultrasound and then we have 2 MR images. The ultrasound is of a patient with cirrhosis. That's what we are discussing today. And this shows volume redistribution in the form of caudate lobe hypertrophy here. You can also see some nodularity of the liver surface here and here, as shown by the pointer. Then for the axial MRI, these are T2 weighted images, and they show nodular contour of the liver with hypertrophy of the left lobe. You can see that this entire thing is the left lobe. It's looking quite big. And then there's also atrophy of the right lobe. The right lobe is appearing a little small, especially the area with the nodularity appearing smaller than normal. Now, as a result of this atrophy, we can see that there is widening of the periportal space pointed to by this yellow arrow. You can see that there's a lot of fat in this area. And then also in the posterior hepatic region, we are seeing this, what we call the posterior hepatic notch sign, as stated in the earlier slide. This space of fat, you see this notch in the posterior aspect of the liver. All these signs are in keeping with hepatitis, and this patient actually had a history of hepatitis C. As cirrhosis progresses, it often leads to portal hypertension, and this causes the spleen to enlarge and promotes the formation of abnormal venous pathways, and shunts or varices would occur due to the collateral pathways. One specific feature is the recanalization of the paraumbilical vein. As the pressure increases, it just kind of forces the paraumbilical vein to reopen, and that's a pathognomonic sign of portal hypertension. So in this image, we have a coronal contrast enhanced CT, and it shows splenomegaly, and also we can see small gastric varices pointed to by this arrow, which are all consistent with portal hypertension. We don't have calipers on this, but you can see that the portal vein is quite dilated. In the spleen, we may also observe Gamma-Gandhi bodies. These are small hemorrhagic lesions that appear on imaging as tiny foci. It will be echogenic foci on ultrasound and hyper attenuating on CT, and will also be hypo intense on MRI. This image is a grayscale ultrasound scan, and we see these multiple echogenic foci in the enlarged spleen. These are Gamma-Gandhi bodies in a patient with cirrhosis. Other findings include gallbladder and bowel wall thickening, as well as diffuse edema and ascites due to low albumin and fluid retention. We classify cirrhosis as either being micronodular, that's when the nodules are very small, less than 3 millimeters, and that's usually linked to alcoholism, or macronodular, where the nodules are larger and are separated by wide fibrous bands. This is the typical appearance in cases of severe viral hepatitis. This image is a coronal reformatted contrast enhanced image. It's in the portovenous phase, and it shows cirrhosis as evidenced by the small and nodular liver. You can also see the dilated portal vein and some of its branches, telling us that there is some portal hypertension going on as a result of this cirrhotic liver. And we can see some medium amount of ascites. You can see this fluid around the liver. Also, the stomach and the small bowel and the colon are diffusely abnormal. We can see the walls are thickened. The stomach demonstrates thickened rugal folds with increased enhancement, and the small bowel is also diffusely thickened and hyper enhanced. And just like we mentioned, that we can have bowel wall thickening as a result of the cirrhotic liver. This is actually a case of what we call gastroenterocolopathy. Gastroenterocolopathy secondary to cirrhosis. Advanced imaging has made evaluation a little more precise. We have what we call MR elastography now, and this uses mechanical waves to assess the liver stiffness, basically giving a quantitative value by analyzing how the liver tissue responds to vibrations. So we are basically checking how stiff the liver is. And sonoelastography is an ultrasound variant, and there's also a non-invasive tool. It uses shear wave or strain based techniques to grade fibrosis, and all these help in managing chronic liver disease. So to summarize, cirrhosis is the end result of many chronic liver conditions. Early signs such as changes in liver size and texture can be detected on imaging, and currently newer techniques like elastography are revolutionizing our ability to non-invasively assess and stage fibrosis, so that we don't always necessarily have to biopsy the liver to see the grade or degree of fibrosis, and this aids in early diagnosis and better management. Thank you very much for your attention. I hope this has been helpful. If it has, give it a thumbs up, share to someone who would need it, and subscribe if you have not subscribed yet. Next, we'll look at malignant hepatic masses, and I will see you in the next one.